on the computer. Tape is rolling. We are now recording. So please mind your P's and Q's, stuff like that. And is that Sidra? Hi, Sidra.
Here. Yeah.
Oh, hi, Jackie.
Hi, how are you?
We might as well give the floor to Jackie and let her explain the whole damn thing again.
Start over, Jackie.
Oh, I'm sorry I said damn.
Oh, that's right. We're on record.
I'm at all sorry.
This is Gretchen.
Gretchen here?
Oh, there she is. Okay.
Edna, you're here twice. You have a glamour shot and you have a sitting down live shot. So we can count you twice.
Edna's important, so she has to have 2 squares.
There you
Oh,
go.
I have 2. Oh,
Yeah, keep it there, Edna. I love it.
She paid more to enter here, so she
Right.
gets 2 squares.
I want to make sure I hear everything.
You guys are funny. Yep, I got Edna there.
We got the whole A team. We got all the A players here except for our main speaker, Catrice.
Yeah,
Wow.
logging in right now.
I want to get one of those, what you call it.
When I emailed her, she was excited. She says, but she was glad that I reminded her, so.
Thank you for reminding her.
If she has slides to share,
I missed that one.
you know if she has slides to share.
You know, she didn't say anything about having slides, so I think she's just gonna speak to us. She
Okay.
didn't say anything about slides, but I did offer that option to her.
I can do some kind of hand stuff.
Be careful.
Well,
Well, we can still start if you all think we should proceed forward.
Go ahead.
let me look at my phone to make sure that she's not trying to email me or ask me questions.
I think she just got here.
Is that
Oh.
Catrice?
That's Treasure. Hi,
Hey, hi guys.
Oh, there she is.
that's Treasure. And are you
Hi.
okay or Catrice? Or both?
Hi. I'm going to speak today. Catrice
Okay.
has another meeting today.
All right. So
Well,
So
guys,
hello everyone. It's great to
you wanna-
Hi.
see your beautiful face.
You want to introduce yourself or?
Sure. My name is Treasure Joyce, and I am the manager of the Neuroscience and Stroke Program here at Providence Little Company of Mary Medical Center. And I have been here at this hospital for about 13 years. And so I'm here to kind of talk about stroke since May is Stroke Awareness Month.
Well, great,
Good.
great. And your name is Treasure?
Yes, that's
What a
my.
wonderful name. Treasure, I'm the host of the meeting and we've got some business to go over and I'm going to
Sure.
start that right now. And then
Absolutely.
Jackie can reintroduce you or myself. But I want to welcome everybody to the 11th Zoom meeting, PEP Zoom meeting that we've had since COVID started. And we have a great speaker today. It's Treasure Joyce, fabulous name, and she's going to fill us in on all the ways to prevent strokes. And if you do have a stroke, she's going to give discounts at Little Company of Mary at your hospital. But as we do every week, I want to thank our hardworking board of directors because they're the ones that keep PEP Pioneers alive. And you know all the things they do. You know about the, PEP Talk. It gets written, produced, distributed. Zoom calls get coordinated. All sorts of stuff is happening behind the scenes to keep this organization breathing and living and sending cards out to people and thanking them and organizing our callers and what our callers say. And so let's give a round of applause to the board of directors, please. Thank you, everybody. I also want to remind everybody that the board works for you all. So if you have questions, if you have problems, if you have complaints, sorry. Please see one of our board members. Okay? Sorry about that.
Okay.
It was a robocall. You guys don't get those, but I get those. Before we go any further, though, I want to bring everybody up to date about the future of PEP. I met with Carol Sakamoto earlier this week to kind of get an update on PEP and maintenance and rehab and what's the status, because pretty soon state's gonna open wide open, probably around June 15th. And I'm hoping that we were all gonna maybe come back then. And I sat down with Carol, and a little bit to my shock, she said that PEP wouldn't probably be returning till July, August, or September, or October even. And probably more than likely, September or October. And they're doing 70 to 80 COVID tests a day. And that's taken over our space in the gym. And when I was there were all sorts of people coming in for tests, and it's a whole different atmosphere right there. And frankly speaking, I was a little bit taken back by what she said. I didn't expect to hear that. And so I said to her, well, maybe, we need to start looking for a different place for PEP, or at least an interim place. And she kind of, to my surprise, said, yeah, that's probably a good idea. And so that was also disappointing. Jackie and I are going to explore some alternate facilities. And one of the possibilities is beach cities. And Jackie has some contacts there. And we're going to set up a meeting with them and talk about if they possibly have a workout facility, and maybe they even have a big room, and their food services can prepare our monthly luncheons, and maybe we can even do our monthly luncheons there. I don't know, but we need to explore alternate sites. And Jackie and I will do some early advance work, and then we'll discuss it with the board of directors and see what their feelings are, and then we'll go from there. And we'll keep everybody up to speed on what's going on. But it's a challenging time, to say the least, for PEP and for maintenance right now. And I know all of us really miss it terribly. So believe me, I want to, as soon as possible, all of us want to be able to regroup and meet somewhere in person. And so
I may be able to help with beach cities, because I did know somebody on the board who helped us before with parking. So I have to make sure that she's still on the board, but if so, I may be able to help.
Well, thank you, Mary Lee. I think Jackie has some great contacts there as well. And so I think we're all set for initial contact there, but
And I also know Vanessa very well, so Vanessa Foster, so.
oh, good. Well, it looks like lots of people in this group have lots of contacts, but I think we'll initially go through Jackie, and then we may be tapping you guys for your contacts as well. And also, I incidentally stopped by the China buffet yesterday to look at a possible luncheon place for us. And the manager wasn't in, but the assistant manager was in, and I explained the size of our group. And initially I explored that, and Carol poo-pooed it and said, absolutely no buffet. And so that killed that. But I don't see why we can't re-look at that if we need another luncheon facility. They have a private room. It fits our needs, great parking. It's a great location. They have a variety of foods, and it's dirt cheap. And we don't have to
Which one is this?
The China buffet on Pacific Coast Highway and Ocean.
Good.
or Madison, maybe. It's near
Okay, okay,
Madison.
Yeah.
And so I think that has some strong possibility as a luncheon facility, but we'll see. The food's not bad. I've eaten there a couple times. The Honda retiree group meets there every Christmas under normal conditions. And so I've eaten there several times. The food's not bad. But today we have a wonderful speaker and with a wonderful name, Treasure Joyce. I just love your name, Treasure. And I don't know, Jackie, if you have any further introduction. I can't tell you all about Treasure Joyce, but her parents were wonderful to name her that name. So, she's got wonderful parents, but maybe.
It was a treasure to them.
Yes.
All children should be a treasure.
And Jackie, maybe you have some other words to say about Treasure and her career and how wonderful she is.
Well, she was kind enough to talk to us several times before. And we have just a really great neuro department now with stroke and they're doing fabulous things with stroke. So, you know, because of Treasure and Catrice, the hospital is just thriving in this field. So we're honored to have Treasure with us today. So welcome, Treasure.
And before Treasure starts, I just want to remind everybody, Treasure will speak from now until about 12:15. And while she's speaking, I'm going to mute everybody, my favorite part. And then after I mute everybody, once we get to Q&A around 12:15 or so, if you want to raise a question, just raise your hand or hit the raise the hand thing on the reactions at the bottom, and a little yellow hand comes up. And Jocelyn will help me recognize those with questions. So without further ado, please, Treasure, take it away.
And Kurt, make sure you mute everybody too, please.
Yeah, and I'm trying to remember where that stupid mute button is.
Also, I just got an email from Valeria that's having trouble getting into the meeting. How can I help her?
Have her call me.
Okay, thanks.
Jocelyn, can you remind me where the mute everybody is?
Participants down at the bottom. So bring up the participants box and then at the bottom.
Oh, I got it. You are all muted. Take it away, Treasure.
All right. Well, thank you guys. And thank you for liking my name. It wasn't my choice, let me tell you. And it's not my stage name, for those of you that might be thinking it's my stage name. My dad was a hippie. And so it was either that, or if I was a boy, I was going to be called Captain. So thank God I'm a girl. And I appreciate you guys letting me talk today. We're going to talk about stroke, and May is Stroke Awareness Month. And I see all your beautiful shining faces, and I'm so excited to chat with you and to answer any of your questions. I'm just going to share some basic information and kind of go over what we can do here as a hospital for stroke, as a comprehensive stroke center, and the different types of hospitals that exist related to stroke. But the most important thing is to recognize stroke. There is no way to predict a stroke. Let's start. There's no warning signs. There's no way to say, oh my gosh, I think I'm gonna have a stroke. It's once you're having it, that's when you find out. And so the faster you recognize stroke, or you see somebody else having stroke symptoms, the faster you respond, the better. So I'm just going to share with you a PowerPoint that I put together and some slides. So give me 1 minute. Oh, so it says here that the host disabled participant screen sharing. Would you mind sharing let me share my screen?
Yes, I just clicked on multiple participants can share.
Ah, there it is. Got it. Thank
Okay.
you. Okay, let me find my slides that I had open. Oh, let me open them real quick. 1 second. 1 second. Sorry, guys. All right. And that. Okay. All right, here we go. Now I'm going to share my screen. All right. Okay. So during a stroke, every minute counts. And I just want you guys to know that.
Treasure, do you have a slide up now?
I do. Can you guys see my slide?
No. There we go.
You guys can see my slides?
Yes.
Okay. There might be sound. I'm not sure if it's going to play through this, but we'll try and see. Can you hear the sounds?
Yes.
All right. So during a stroke, every minute counts. I want you guys to remember that. Okay, so stroke is a medical emergency. We need to treat stroke as a medical emergency, and it wasn't actually until probably the late 90s when we actually treated stroke as a medical emergency. Back when I first started nursing, we actually would discharge patients home from the hospital that came in through the ER with a potential stroke and send them home usually on aspirin. Unless they were waiting for rehab, we really didn't treat it as emergency because we felt like there was nothing we can do. But in the 1990s, they developed, there was a clinical trial that started, it was called the NINS trial. And that trial looked at what we were doing for patients that actually had a heart attack. When patients had a heart attack during the 90s, we were actually giving them medication that would break down the blood clot in their heart. Like, I don't know if you guys remember the ads in the 80s where a patient was having a heart attack or somebody was having a heart attack, and then it was like from the American Heart Association, or maybe it was a Bayer commercial, I think. And then they were on playing basketball or something, then they would grab their chest and then we'd give them an aspirin and they were okay. And so they kind of thought, well, if we were, can we do the same thing for stroke? Because stroke was actually probably the second leading cause of death and disability in the United States at the time. The National Institute of Health launched this clinical trial that looked at how could we treat patients with stroke and treat it as a medical emergency. And so what they found was using this medication, it's called TPA or Alteplase, but basically it's a clot busting medication. And if we were to use that medication and use it rapidly, then within a certain time frame of the time the patient's stroke symptoms started or the last time they were known well, then we were able to decrease the potential for death and disability by 30%. And that's a huge number when you start from nothing to something. So 30% was a big deal. So we started to really focus stroke in probably the I would say 1996 to 1999 is when it really started to change as far as an emergency. Hospitals then would call a code stroke. Oops, that didn't work. Do you see my slide there? Let me see where it went. Okay, so what is stroke? Stroke is a lack of blood flow to one or more parts of the brain. So if you see my slide here, this is the brain, and these are the blood vessels going to the brain. And when you don't get blood flow to that area of the brain, what happens is this area now becomes damaged. And these are your brain cells and the nerve fibers that travel to send the messages from that side of the brain, which is actually what your body uses to function. So if you want to move your right arm, your left side of the brain would send a message from your brain cells through the nerve fibers, and then your arm would move, and vice versa. And so without blood flow, that area doesn't function. So for every minute that passes by, for 1 second, 32,000 brain cells are lost. That equals 8.7 hours advances in your age in the brain, or the advanced age in your brain. For every minute that passes by, 1.9 million brain cells are lost, which equates to about 3 weeks of advance in age in your brain. And for every hour that passes by, and this is during a stroke when there's a lack of blood flow, by the way, 120 million brain cells are lost, and you lose about 3.5 years of age in your brain. If a stroke is allowed to complete, 1.2 billion brain cells are lost, and that equates to 36 years advanced age in your brain. That's a lot. So what do we do? What do we do about that? Well, we need to figure out what the symptoms are and what happens during a stroke. So symptoms of the stroke vary on depending on where the brain is or where the lack of blood flow is happening. So in the front part of our brain, we use that part of our brain for problem solving, emotional traits. We have judgment, our reasoning, some of our speaking, and some of our voluntary motor movement. It all comes from this front part of our brain. In this parietal lobe here, in this side, this yellow part of our brain, that's our ability to know our right from left. That has to do with sensation, how we feel, how we interpret things, reading, and how we interpret our body orientation. This back part of our brain is looking at vision and color perception. The bottom part of our brain here, our cerebellum, has to do with balance, coordination, control of voluntary muscle movement, and fine motor control. Our brainstem looks at breathing, all the things that you guys don't have to think about. Breathing, body temperature, digestion, whether you're alert or sleepy, and whether you're able to swallow, that's all coming from our brainstem. And then our temporal lobe, this blue area, is looking at language, behavior, memory, and our ability to hear. So if you recognize any symptoms when you have all of a sudden a problem doing any one of these things, well, that can give you an idea that you're having a stroke. And so when you respond immediately, you can limit the damage that's occurring in any part of that brain. Again, driving home that stroke is a medical emergency. So what do we need to do to identify stroke as a medical emergency? Of course, you're not going to remember all of those things that I just showed you here. You're not going to be able to kind of know that this is happening and identify a stroke based off all of those tiny little things that our brain does, all of those skills. However, we developed an acronym, and this is a nationally used acronym, and it's called BFAST. And BFAST stands for specific things, and we want you to be fast. So I think that you get it, that we want you to respond as a medical emergency and be fast when a stroke is occurring. So B stands for balance, the E stands for eyes, F stands for face, the A stands for arms, the S is for speech, and T is time. We're definitely driving home the time situation. Always, always call 911. Why do we call 911? Because 911 will definitely, the paramedics, especially in LA County, by the way, have a protocol, and they follow this protocol. And the protocol says, if somebody is having these type of symptoms, so the paramedics are trained to respond to medical emergencies, but the types of medical emergencies may vary. One of the things that they're taught to identify is a stroke. And if a patient is having a stroke, they have a knowledge of which hospitals are certified as stroke centers. And there are primary stroke centers, and and then there are comprehensive stroke centers. And so if somebody in the field, and somebody in the community is looking like they're having neurological signs and symptoms, and it might be small, then they would be, and there's a primary stroke center closest to their house, they would take that patient to the primary stroke center because time is brain, and they want to get to the fastest hospital that's capable of taking care of that patient. But if the stroke symptoms look like they're where a big part of our brain is affected, and it looks like it's a very big stroke, for example, somebody's not able to move the entire side of their body and not able to talk, and they're looking in a different direction, then they might decide to take that patient to a comprehensive stroke center, because that stroke center can actually do advanced treatments where they can go in and help prevent or help get a big stroke, make a big stroke, or what would be a big stroke, into a small stroke by bringing blood clots out of the brain. So that's important. So how do we recognize these symptoms? Let's talk about B, which is balance. And remember, I showed you that slide that had the back of the brain where we're talking about the back of the brain focusing on balance and coordination. So if you have an acute onset or a sudden onset of loss of balance, and this just goes into all that B fast. Let me skip this slide here. Arms, speech, and time. again. And you want to call 911. So you definitely want to recognize this and call 911. So the B is balance. This is a sudden onset of trouble walking. This happens really quickly. Somebody might all of a sudden feel dizzy. And then when they try to walk, they walk kind of towards one side. This is a sign that you might be having a stroke in the back of your brain. This is actually really hard to identify. But when you do catch it, this is a big lifesaver, because if you do have a stroke in the back part of your brain, time is of the essence because it's really close to your brainstem. And people that might have a big blockage back there have less time for that stroke to evolve and cause them to have respiratory failure and all kinds of other things. So this is an important symptom to recognize and call 911. When we talk about the E and we're looking at eyes, we want to know if there's any sudden, always sudden, loss of vision. Is there a blurry vision? Are they having double vision? Maybe is there a drooping in the eye? What is going on with the eyes? Did it all of a sudden happen? This is another sign that that back part of our brain is having trouble and we need to act rapidly. F is for face, and this has to do with the patient's facial droop. Sometimes a stroke will occur and our face will, the nerves in our head will be infected and they won't be able to fire. And so to keep our facial muscles up and active, so then our face would droop. And so does the person's face suddenly look uneven? If you have trouble telling, ask that person to smile. If they're not answering you or they can't follow commands, give them a little pinch and see if they grimace. That can also see if you can tell if a patient is having trouble, or somebody in your community, a family member or loved one, is having trouble smiling or is having a facial droop and having a stroke. A stands for arm. Is the person able to raise both arms? And when they raise both arms, are they able to hold those arms together simultaneously, or does one arm seem to drift down? Sometimes we could have weakness in the arm, but not paralysis. And when you have weakness, you can definitely lift that arm against gravity. But what tends to happen is that we can't hold it up. And so that arm will drift down kind of slowly, and we will lose our ability to keep it up there simultaneously with the other one. That is also a sign that there might be something going on, like a stroke, and that we're having a loss of function in our brain. S stands for speech. And this is what we would say. You want to ask the person to repeat a simple phrase. Ask them to say mama, tip top, what time is it? Huckleberry, any one of those. It doesn't have to be those, it could be anything. But is there any slurring in their speech? Or is their speech strange? Are they not answering you appropriately? Did you ask them what day it is? Did they say like George Washington? Is it appropriate? Does it make sense? Or is it jumbled? Are they mumbling, or are they having trouble speaking at all? Are they looking at you and you could tell in their eyes that they're able to hear and receive what you're saying, but they're not able to make the movement of their mouth and the words come out? Is it broken? Are they only able to get one or two words out? Does it sound like it's stuttering? Does their voice sound hoarse? There's all kinds of things in speech that you can look for, but basically just know if they're talking funny and it's all of a sudden, then that's an important thing to know, and that we need to call 911 fast. And T is for time. It's time to call for help. You definitely want to call 911 again, because our emergency medical services has protocols to get patients to the appropriate facilities. So they will respond and they will get you to the right hospital and in the fastest time. What else? What other symptoms should you know about stroke? Again, numbness or weakness. So sudden onset of numbness or weakness, especially in one side of the body, is important. Sometimes it's often missed. If we say, okay, is it just the arm? It could be just in the face, it could be just in the leg, but it's usually just on one side. Sudden onset of confusion. A lot of times this might happen first And we don't necessarily look for weakness because the person that we're talking to, our loved one, is all of a sudden confused or acting funny. And it just happened all of a sudden. And so we're so focused on the confusion or the way they're acting that we don't really identify the weakness because we're concerned about how they're behaving. If they're having trouble seeing in one or both eyes, all of a sudden a loss of vision is an indication that there might be something happening. Are they having trouble walking? Are they having dizziness? Are they having a loss of balance or trouble with coordination? Those are all big signs of that there might be something going on in the back of their brain. And this one is really a big one. Do they have a sudden and severe headache? And we're talking about a lot of these symptoms could happen for any type of stroke, a bleeding stroke or a ischemic stroke, and we'll go over that in a minute. But in this bleeding strokes typically have somebody come in with a severe headache, but it doesn't mean that that's what a bleeding stroke is. It can also be an ischemic stroke. So you want to know if there's a severe sudden onset of a headache. And a lot of times people will say, it's the worst headache of my life. It just came on out of nowhere. Some people say, oh, it's like a thunderclap headache, or it just happened. And some people even yell out and then they lose consciousness because the headache was so bad and so sudden. It is very important to activate 911. Again, I can't drive this home enough when you recognize a stroke. So are there any questions? I have 15 minutes and we can go into, I'm going to stop sharing my screen. We can go into the different types of stroke if you'd like that.
Treasurer, I have a question. This
Yeah.
is, do the 911 crews have some drugs that they would administer immediately upon finding me in the driveway with one of these classic symptoms? Will they give me some sort of IV or something to treat me on the way to the hospital because time is so critical?
That is a great question. As a matter of fact, there's a couple scenarios that can occur. The 911 currently has a system where they don't have that clot buster in the rig at this time, but they can give you medication like aspirin, and they can give you medication to keep your blood pressure at a certain point. But their main goal is to make sure that you're able to breathe and to keep an eye on you, to do an EKG to make sure that you don't have any abnormal heart rhythms. They also will check your blood sugar to make sure that your blood sugar isn't what's causing this all of a sudden change in your functioning status. And then they can, treat a lot of emergent things, but they won't be able to really provide you that clot buster, which is really important to get it. So that's why they call in, and usually they call in while they're en route to the hospital and their base station and get directions from their base station. They go to the appropriate hospital. There we'll be able to treat you right away. So what they do is they're able to call in ahead of time, and they're able to talk to someone. So when we get a call from the paramedics saying that somebody's coming into the hospital with a stroke, we already know that that person's coming. So we announce something called a code stroke, and it's paged overhead. So all of our stroke team hears it, and we meet you in the ER because we know that time is brain. So as you're coming in to the emergency room from the paramedics, we're waiting for you. And there's going to be several people there all around your bedside doing all kinds of things simultaneously so we can get you to the CAT scan, which we call the donut of truth. And Liz would tell us what we're going to see. Are we going to see what kind of stroke it is? And can we get you that medication as fast as possible? And that's our goal. So the paramedics are super important to give that. There is another sort of one-off, and that's and another sort of process that happens in LA County, and it's called the mobile stroke unit. Have you guys heard of that? No? Okay, so this is the mobile stroke unit is only in the South Bay, and they're up in the Torrance area and Gardena. They're at a specific Torrance station, and they're here Thursdays through, I think, Saturdays. And they're here from 10 a.m. to 7, or no, I'm sorry, 7 a.m. to 10 p.m. On Thursday through Saturday. And then they go, sometimes they're in, and then certain parts of the week they're in Westwood, certain parts of the week they're in Long Beach. And currently the mobile stroke unit is supported by a grant from UCLA, and one of the alums at UCLA who pays for this, who put together funding to have an ambulance that has the donut of truth inside of it. So I don't know if any of you have been in a CAT scanner, but it's basically like a circular X-ray machine, right? And so we just kind of slip you in on a table and do X-rays of your head to see if you have any bleeding, or if it looks like you've had an old stroke or what's going on. So they have that inside the rig itself, so inside the ambulance. And they're part of a clinical trial that's looking at how quickly they can, they'll enroll you in a clinical trial, they'll bring you in, and then they'll you'll have to sign a consent, and then they're able to identify, if it sounds like you have stroke symptoms, they're able to give you that clot buster in the actual ambulance, because it's staffed with a nurse and a doctor and a technician that runs that CAT scanner. And so that's been here since 2018 in the South Bay.
So we all should have a stroke during those periods of
Just
time.
only Thursday through Saturday, guys. That's it. No, but to be honest, that is effective. It is effective treatment, but they're only in a certain location, and it's for a clinical trial. It really is the most effective, by the way, because there's a couple nuances with it. You know, they have to have a flat area to be able to perform this CAT scanner. They have to stabilize the rig, so there's a little bit of a process. It's not as simple and fast as you would think, but really, it's really effective more in the rural areas where people can't get to a hospital quickly. And so they are doing trials in Virginia and Texas, and that's where those trials are really based out of. And they have a lot of impact out in those areas where hospitals are so far apart. However, we're all lucky and blessed to be in an area where there's hospitals, like, for example, Torrance Memorial and Little Company of Mary. They're within a mile of each other. And I think that's because we have so many people in a small area. So that helps provide services. So it would only take a matter of minutes to get to the hospital to get treatment in our area. And it's more effective to get to the hospital first sometimes, because then you can also get that blood clot out if it's a big blood clot.
Thank you.
You're welcome. Does anybody else have any questions? Oh, I see a hand. Millie has a hand up.
Treasurer, I was curious about the ischemic strokes, if you could explain that in a little more.
You bet. Let me see if I could pull something up here. Let me just pull up the slide that I had. Hold on. Okay. All right, I'm going to try and share my screen again. Here we go. Okay, can you see my screen?
Not yet.
Okay, oh, I have to hit the button that says share. That's probably why. Okay, how's that?
Yes.
All right. So this is looking at types of blood vessels in a stroke. This is very, very busy. Don't pay attention to any of these words around here. But an ischemic stroke would mean that you would have a blockage in a blood vessel. So ischemic or ischemia, it basically means narrowing. And so it could be narrowing from plaque built up in the artery, from cholesterol and just the way our lifestyle and all of that. And so that's why we go to the doctor and get cholesterol taken, because plaque has a tendency to be in our blood. And then if plaque finds its place to land, if plaque decides we have enough plaque in our blood system, and it finds a place to land, it usually likes to land in a spot, usually in an artery, and it will narrow, or it could land in a vein. But typically, when it lands in an artery, it sticks up to the wall. It's very sticky, and then other plaque will build up on top of it, and that plaque will become an area where there's narrowing. And so it takes just one, either that plaque can break off, and then blood will clot and form at that narrowing, or a blood clot can come from someplace else in our body, like let's say our heart, if we have something called atrial fibrillation, and that clot will travel to our brain and block the blood flow. And so what we do to treat that is we're able to provide medication, one, to get that blood clot broken down, which is that clot buster, but we're only able to provide that clot buster medication in a certain time frame. And we currently do have some studies that were performed that looked at using that clot buster in an extended window outside of that time frame, but you'd have to have extra imaging to look at, and it's on a case-by-case basis. But we really try to break down that clot first. Another way to treat that is by doing something called a thrombectomy. And this is sort of a pictographic version of what a clot would look like inside the blood vessel of the brain. And we would take this particular catheter, which is really, really tiny, smaller than your cell phone charger, and we'd bring it all the way up into the blood vessel. And then we'd put in this particular catheter. We call this a stent retriever. And it has like kind of a metal cage, and what it does is it kind of adheres to the clot itself. And then we're able to put a little bit of suction at the end of this, and we're able to gently pull this clot out in one piece, like this you see here in that little picture number 4, and bring that clot out of your head and restore the blood flow.
Jesus.
And so what that would look like in an image would see, this is an actual image of somebody's brain, and we inject dye into the blood vessel, and you see right here that there's no blood flowing through right here. I don't know if you can see my thing, but right there's no blood flowing through. And after the procedure, you could see that blood flow right through and surround this whole area.
Wow.
And so now we restored blood flow. So our goal would be to make a stroke that was probably happening, and it probably did happen. And so, but to keep that area small, so we took a big stroke and made it into a small stroke. And so this is another picture of what it would look like. Let's see if I can do that. And this is what the clot would actually look like.
Oh, Jesus.
So they're very, very long, and they kind of build up in the blood vessel because the blood vessels are long. And so they're very long and skinny, and they get stuck there. And so that's basically what you would see in an ischemic stroke.
Wow.
That's pretty crazy. So do you guys have any other questions? Yes.
Sidra and Gretchen.
Okay.
Sidra, go ahead and unmute yourself.
When you say that it's a very time sensitive, what are you talking about? I mean, how are we talking, seconds or minutes, or does it matter?
It doesn't really matter. Mostly, for every minute, 1.9 million neurons die, right? So that's why we're saying it's time sensitive. And the best thing to do, again, to reinforce this, is to call 911. Even if you have a family member there that could drive you to the hospital, you want to end up at the right hospital And so it's better to call 911 and have the paramedics come. They have very fast response times. And so it's really helpful to get, and then it also, the paramedics will be giving us information ahead of time and letting us know that you guys are, somebody's coming in, right? So they're gonna let us know that they have somebody in their ambulance and they're headed to our hospital. And so we'll be waiting. And that's the fastest way to pull the trigger to get to identify stroke.
Thank you.
So Treasurer, if time is so critical, even down to the minute, why does someone that arrives at the hospital in a 911 ambulance and then they got to send them to get a CAT scan before they decide to give them a clot buster?
That's a great question. You know why? Because we need to know, because stroke can be two different types. You can have a bleeding stroke, or you can have a hemorrhagic stroke, a bleeding stroke, or you can have an ischemic stroke. And so it's our job to identify if there's blood in the brain or not. And so that's what that CAT scan does. It'll identify any blood in the brain for us before. And that's important because you don't want to give blood thinner to somebody who already is bleeding. That would make it worse.
The hospital obviously has expedited processes.
Yes, yes.
Down to the CAT scan and back.
Right. At Little Company of Mary Torrance, we have something we teach the nurses and the staff in the emergency room, and we call it 5 in 5. So we want to get 5 things accomplished within 5 minutes, and we want to get you to the CAT scan because we have to know some information. One, you need to have an IV. That's super important because we need to be able to inject dye into your blood vessels to see if there's anything else going on in your blood vessels where there might be a blockage, just like I showed you in that picture, or if you might have an aneurysm that's bleeding. So we need that IV, and also we need an IV to be able to give you that blood thinning medication, that clot buster. We also, so we fasten the IV and we get some lab work because if there is something going on, we need to know what your blood glucose is, one, to make sure that you're not having any issues with low blood sugar, because that can also mimic a stroke. And instead of giving you a blood thinner, we could give you glucose and then it's gone. And all of a sudden your stroke is gone because you really didn't have one in the first place. So we need to really make sure that it's a stroke. We don't want to give them a blood thinner to somebody that's just got low blood sugar. Gotcha. We also want to be able to identify, when the last time you were known normal, when was that last time? Because that's super important for us because that will guide our treatment. Can we give you a blood thinner, or is it too late to give you a blood thinner? Because if we give you a blood thinner too late, then we could cause another injury. We could cause more bleeding. So we really need to get that information. We need to know what your blood pressure is. That's super important because we want to make sure your blood pressure is stable before we give you any medication. If you have an ischemic stroke, we need to make sure it's down to a certain level because if we're going to give you that blood thinner, we don't want your blood pressure too high and break that artery. So those are some important things. And we also want to make sure that you're able to breathe and speak and everything like that. So that's a super important thing. So, if we need to put a breathing tube in to help you breathe and because you're not able to keep your airway open, that's also important. So just doing that in 5 minutes, and then we're taking you to that donut of truth. And then we decided whether it's a bleeding stroke and what our care is for that versus whether or not it's ischemic stroke. So do we reverse the bleeding or do we treat the clot that's causing the narrowing and the lack of blood flow? So we have 2 sort of pathways that we can take, but we definitely need to identify which pathway it is first.
Thank you. Somebody else had a question.
Gretchen, go ahead, and then Pat will be next. Gretchen, make sure you unmute yourself first.
Yeah, I was wondering if you'd talk a little bit about TIAs. We've all had them at our age, most of us. And what do you think? I knew I had one a couple months ago.
Okay.
And it went over and I said, I'm having a TIA. But I said, maybe I should call my cardiologist. He said, come in, EKG, and I'm on Wayfair, and so it didn't. Well, I saw my general practitioner yesterday, and he said, I don't think you. How do you know you had a TIA?
What's a TIA?
That's a great question.
Tell me, what is it? Tell us.
Well, that is a great question. I'm glad you brought that up, Gretchen, because the TIA is actually a they say mini stroke, but it really isn't a stroke. It's a warning sign. So TIA stands for trans ischemic attack, meaning that you're having stroke-like symptoms or stroke symptoms, but for some reason, your body changes, the clot moves, and that clot resolves itself, and then you don't have a stroke. So it was like a tease, like it's like, okay, you're gonna have these symptoms, but if those symptoms go away within 24 hours, then, and it could be, a facial droop, it could be arm weakness, it could be any one of those. It could be just difficulty talking, or for a transient moment that you were confused, and then it goes away. Then it's not necessarily a stroke, but it's a warning sign. It's your body saying, hey, guess what? You got something going on in here, and you need to make sure that you get medical help. So even if you have a TIA, you need to go, no matter what, if you have stroke symptoms, even if they resolve, get to the hospital, because we could identify the reason why you're having a TIA. You need to get worked up, and you need to get worked up quickly. And unfortunately, those of us with AFib that are on blood thinners or on sort of medications like that, or we have we have AFib, but we're not on blood thinners, or maybe it's here, our AFib's here for a little bit and it's not here, and so or sometimes we just don't know that we have, a abnormal heart rhythm, right? And that is a big problem, because those can also cause a lot of TIAs.
Thank you.
You're welcome. So definitely, if you have any signs and symptoms of a stroke, even if it goes away, go to the hospital, because we can do tests. We can test your blood. We could put on your heart on a monitor to see if you have an abnormal heart rhythm. We could check an ultrasound on your arteries in your neck to see if there's any plaque in your neck that's causing symptoms of a stroke. There's all kinds of reasons why you could have TIAs, and it's a warning sign, and it's really important to not ignore.
Thank you.
You're welcome.
Pat, go ahead, and then Brian.
Treasurer, my question is, do both Torrance Memorial and Little Company have the ability to do that thrombectomy?
Yes, ma'am. We are both comprehensive stroke centers.
Great. Thank you.
You're welcome.
Brian, go ahead.
I was just wondering, what do you call a clot in the lungs? Is that very common, or what are the symptoms?
Yes, so a clot in the lungs is not a very common thing, and a clot in the lungs can be indicative of a clotting problem all over your body. And your clot in your lungs is just typically from a hypercoagulable state. So a state where that means that your body just likes to clot the blood. Like your blood likes to sit still and get little clots everywhere. And that is a problem. And it's called a pulmonary embolus. And so that sits in there and so if you most people that have it will have chest pain or something like that, or have difficulty breathing, and they'll be able to identify that. And you usually are treated with blood thinners and works up to find out why that blood clot is there, why your blood is clotting in your lungs. And so they'll look at different types of things. They'll test your blood and everything, and then and it, depending on the reason, they might have to put a filter in to prevent your blood from clotting, stuff like that.
I had a pulmonary embolism when I was in the hospital, and they moved me up to critical care and gave me a bunch of blood thinner, and it was for another reason that I had the clots. But anyway, it wasn't fun.
Yeah, and they're usually from some other reason. It's not, you just don't walk around. It's not a disease itself. It's usually caused from something.
Is there this, my sister-in-law is gonna have a Watchman put in her.
Ah, okay.
In New Jersey.
All right, good for her. So do you guys know what a Watchman is?
No.
So it is a device that is used to help with atrial fibrillation. So there's ways to treat, how many people have atrial fibrillation in this call? Raise your hand. Okay, there's a handful of us, right? So atrial fibrillation is an abnormal heart rhythm that just sometimes happens. We don't know exactly all the reasons why. If you've had heart surgery in the past, if you've had a heart attack and your heart's kind of bigger and enlarged, or some sort of injury where, you know, or you have just generally abnormal electrical conduction in your heart. And so the top of your heart, because your heart beats like this, it goes boom, boom. The top of your heart squeezes and then the bottom squeezes, right? And so this top part of your heart is the atrium. It's the first boom. And sometimes it doesn't boom. It does this kind of quiver movement. And so there's a pocket on top called your left atrial appendage. And that pocket is a perfect place for a clot to form. And so when that clot forms, and because whenever blood sits still, a clot will form. So that's why everybody talks about walking and exercising and that kind of stuff. And then that's why those people that have that issue will be on a blood thinner, because that takes only 30 seconds for a clot to form in that little pocket. Before that pocket, if that atrium, that first boom, finally decides to squeeze, it will squeeze that clot into our nominate or into an artery that goes straight to our brain, and it can cause a stroke. And so the Watchman is a device that they put in that left atrial appendage, and it has like a filter, and it protects that. It breaks up clots, so it stops clots from squeezing out of that appendage. And they're able to do it through the groin and go up just like they would do a heart cath. So they don't have to open your heart up. They would do it like they would do just a thrombectomy. It's just a tiny little catheter that they navigate through your arteries.
Does it come with a 50,000-mile warranty?
Yes, it does. It comes with a warranty. Anytime you get a device, you'll get a warranty.
So Treasure, is it kind of like a filter?
Yeah, it is a filter.
Okay.
Yeah, and there are some people that are candidates for it. You could treat atrial fibrillation by, it could be, you would treat the heart rate. You know how fast your heart is beating, so you might have to take a medication to treat the rate. Some people might, not be able to tolerate the medication, or the medication just doesn't work, and so they might need a pacemaker to help pace their heart to manage that rhythm. And some people might have to just be on blood thinners to prevent the clots from forming as well. So there's multiple ways to treat that abnormal heart rhythm. You're treating the rhythm, and you're preventing clots from forming.
Wow. Interesting.
Mm-hmm. Are there any other questions? I see Nancy has a question.
Nancy, go ahead and unmute yourself. There you go.
Okay. I have a question.
Yes, ma'am.
I just recently lost my cousin
Oh, I'm so sorry.
to what her son thinks is possibly a stroke,
Okay.
because she'd had a lot of the TIAs,
Mhm.
plus she'd had a major stroke a couple years ago.
Okay.
Now she lives by herself.
Mhm.
Would that stroke have taken her immediately?
It can. It certainly can, especially if it's a big stroke. If she's already had damage to her brain, she doesn't have much, and if she's already had stroke that's injured part of her brain, she doesn't have, and she might not have had much reserve. Obviously, I don't know what the issue was, and it also could have been in the whatever location of her brain. So if the stroke happened in the bottom of her brain, back here, it could very quickly evolve to put pressure on her brainstem, which controls our heart rate, our lungs, our heart rate and our breathing, and all that stuff we don't think about, and it could very well be fatal.
And she would have gone quickly?
Yes, those things evolve very quickly.
Okay, thank you.
Mm-hmm.
we have time for one or two more questions.
Treasurer,
Yes.
I have one more. She
Sure.
would have gone quickly and would she have been out of pain?
So that's a great question. You know what I want you guys to do if you have time is I'm sure now you guys are all savvy on the internet. Clearly, you're participating in this Zoom. But if you guys have time, I want you to look up this person who's called, and I'll put it in the chat so that you can see where the chat is. And her name is Jill Bolt Taylor. And she's done a TED Talk and she's on YouTube. And she talks about the experience of having a stroke. And most oftentimes, those that have a stroke, if it's not a bleeding stroke, usually avoid having pain. It's more of a loss of sensation. And so I would watch that to see, she had a bleeding stroke, but she talks about kind of her experience, and it might give you some insight to maybe what had happened. I don't know for sure what had happened to you, her, but just so that you have that. It was your cousin, right? I don't know but maybe that might help answer some questions.
Okay, thank you.
Treasurer, how does food get into your lung?
That's a great question. So when you lose your ability to swallow, when those muscles are affected here, then you have it to, it's your trachea, right? And it's your esophagus, and there's a valve in between that diverts the food to go into your stomach, right? And the air to go in your lungs. So it's a valve that just mostly diverts food and liquid into your stomach. If that muscle or that mechanism is injured, or it's not functioning like as if you lost consciousness or something, then that's how food can get into your lungs and cause pneumonia. But most often it's not just food, it's usually liquidy. So like vomiting is really what is the one reason people might aspirate, or water is the one that's, or liquids, just plain liquids would be the ones that cause people to lose that swallowing mechanism, and water is really easy to get into your lungs and cause pneumonia fluid. Go
This is
ahead.
very scary.
I know.
Treasurer, Jackie, you've got a question, last question.
Yeah, Treasurer, is this why we thicken our waters after a stroke?
That's exactly it, because that valve, that mechanism works a lot easier with thickened liquids or pureed food.
Great. Okay, thank you.
Treasurer, on behalf of the whole group here, and it was a huge turnout. We had 28 people, and that's the largest number we've had in quite some time. So I really want to thank you for an outstanding presentation. Please, everybody, give Treasurer a nice round of applause.
Thank you, guys. I love joining your group, and I love seeing your shining little faces, and I'm happy to join anytime. And I'm sad we couldn't get together because you guys have so much energy and you're so fun. I love physically seeing you, but maybe in the next time around.
Okay, thanks so much.
Take care.
Bye-bye.
Okay, bye, guys.